Right, so we'll start. My name is Dr. Jonathan Yen. I'm one of the chronic pain doctors here. I'm happy to introduce Dr. Juan Francisco Asenjo. He's a professor of anesthesia and pain management at McGill University. He trained at the Catholic University in Chile, and then at the University of Montreal in cardiac anesthesia, and then at McGill in pain management and regional anesthesia. He's been staff at McGill since 2000 with the specific mission of developing interventional pain management in cancer and non-cancer pain, as well as doing regional anesthesia there. His present research interest is actually applying interventional techniques to allow prehabilitations in patients with pain waiting for surgery. Today, he's going to come to help discuss with us how about developing a cancer pain program, which is what we are planning to do here. So please welcome Dr. Asenjo.
Thanks for the introduction, John. It's a pleasure to be here. I want to thank John and Norm and Mauricio Forero for inviting me, and meet so many interesting people here. Excuse me for my voice. A bad cold, and without much other things, I would like to start. They asked me to put a slide with my conflict of interest. I did some consulting for Pfizer and J&J in the past, and every man has his own price. There's a code in there, you guys need to write. And I come from the Patagonia. I was born in Santiago, in Chile, but I live in the southern part of the country. And this is to say that many people think that Patagonia is all Argentina. It's really the lower tip of our Americas, down all the way to the Cabo de Hornos here. And in that area, there is a very interesting program about cancer pain that has been developed by a friend of mine in this area of the country that combine people from all Latin America, pain physicians, to come once a year. We treat like 200 people in a weekend, and then we all go away and we come back next year. And we teach the family physicians in there how to continue the treatment. It's very interesting. I'll come back a little bit about Patagonia in the presentation. I didn't want to start the important part of the talk without telling you about some people that were very influential, not only in chronic pain at McGill in Canada, but also and especially in cancer pain. That guy you see him there, you may recognize. He's an urologist and surgeon. His name is Balfour Mount. Val was instrumental in developing palliative care in Canada, not only at McGill. A big name on that. And he's Val now, or a couple of years ago. He's older and sick. You see, he has a tracheostomy, and still involved in educating people at some point. This person here is Ron Melzek, world famous guy because of his contribution to the physiology of pain, the understanding of what's happening in the dorsal horn, and many other things. And in this picture, we have, probably don't know who this guy is, Wilfred Penfield, the guy who let us understand the homunculus in the brain and where is the pain and where is the motor part and all that. And a great physician at McGill, and there's a street in Montreal that has his name. This guy that is with Ron in this picture, this gentleman, is Alan Edwards. And the connection in here is that ran the pain clinic at Montreal General for many years. And at some point, this clinic needed to expand. Ron wanted to withdraw from his role in there. He was about 70 years old at the time. And he was treating with the clinic Alan's wife because of headaches. And Alan was an entrepreneur and a very well-connected guy. And he created a huge fund to support the pain clinic at McGill. Really a large endowed fund. And this fund also helped to create the cancer pain clinic at McGill. Finally, this guy in here left big roots at McGill. His name is Philip Bromwich, and he did seminal work at McGill in the 70s on the effect of epidural opioids in acute pain and in chronic pain. But also, he was the master of all the studies on epidural and cardiovascular effects and the effects on the muscle. And he has a fantastic book on epidurals and so on. So there's a big legacy in there that we have continued working for. But let's go to see what is the cancer pain clinic that we developed over the years with the support of the Alan Edwards Foundation. And the idea of the cancer pain clinic came from a joint venture between the Alan Edwards Pain Management Unit and the Department of Palliative Care. The Alan Edwards Pain Unit was dedicated to chronic cancer, economic non-cancer pain, and after the point of the merge with the palliative care to create a cancer pain clinic. Before, all of us working in there were doing cancer and non-cancer pain. On the other side, the palliative care or cancer pain support care program at McGill had several different areas: palliative care, cancer rehabilitation, cachexia, lymphedema, psychosocial oncology, transport, and they had also a component of cancer pain. However, this part was, I would say, hypertrophic. It was developed to a level that was rather initial and had a lot of potential to expand. But it was very interesting to discuss with them the development of this thing over time. And I'll show you how this began to crystallize. So what they were doing in palliative care was what palliative care does in many places. We have a patient that at this point start to develop a disease that is a type of cancer that start to deteriorate the condition of this patient as the disease grows and erodes the patient's ability to do things and to develop his life. And this erosion can be so intense when the patient's pain is out of control. When Dr. Carly, the chairman at the time, hired me to do what John said at the beginning, I had this experience with the friends in palliative care that was very good for everyone. Basically, I was doing my clinic in the pain clinic, and we were receiving consults to see cancer pain. And with the nurse that we were teaming up, we would see the consults very fast. Same day, the most next day. Until a few months when the chief of palliative care at the time came to talk to me. And she was not upset, but she was curious of this initiative of the pain clinic of seeing the patient so fast. Because they would take 24, 48, 72 hours to go to see the consult. So she saw so nice. And she said, Francisco, what's going on in here? I says, Anna, I think finally here, maybe need to speed up a little bit because cancer pain is an emergency, is bad. When people are asking consults to come is because the physicians that are taking care of that patient are unable to control pain. So why don't we team up and we speed up a little bit the process and we work together. She was very happy with the idea. So here you see, this is in blue, 2001-2, and then 4-5, and 8-9 in there. So the number of consults was growing, and the number of consults because of cancer grow much more, and the interventions start to go up as the years were passing. So this collaboration, instead of separating palliative care and the pain clinic, actually start to put us together because they were interested in us being involved and help them with a more expedited way of controlling the pain in these patients. Until the end of 2009, when a proposal was put together between the chief of palliative care and the chief of the pain, to try to come up with a service that would specifically come to help this population. So there was a proposal for the development and implementation of a comprehensive cancer pain service. And up to that point, the patients going to palliative care had a life expectancy was shorter than 6 months, as opposed to a pain center, long life expectancy, patients with a symptomatic multi-organ involvement, a condition not directly related to cancer, and acute chronic post-operative pain. So what were the new criteria to refer patients to this clinic? First and foremost, they had cancer diagnosis. Second, the pain is the result of the cancer or its treatments. So, for instance, a patient with breast cancer that was, let's say, 60 years old and was referred because of neuralgia of the L5, the root, a radiculopathy that was not related to cancer, was not an epidural metastasis, there was no mets in the L5 and 4. That was a classic non-cancer pain. That patient would go to the chronic pain clinic, not the cancer pain. And finally, the basic pain management strategies have been tried and failed. So if the palliative care team was seeing this patient and the patient was going out of hands in their condition, they would consult the cancer pain clinic. And once the cancer pain clinic would stabilize the patient, would go back to the standard palliative care team. So you guys know that we have a huge amount of new cases of cancer. This is Canadian figures from 2015. About 100,000 new cases of cancer in male, about 96,000 female, and that was the distribution by provinces. By far, Ontario and Quebec have the most, the largest numbers. And if you see in there, 2 in 5 Canadians will develop cancer in their lifetime, and this total number were diagnosed in 2015. So the proposed model that we had required the creation of a program that not only was clinical, but also was administrative, involved nursing, involved administration, and require some other players, like the people from radiation oncology, interventional radiology, and perhaps orthopedics and neurosurgery. Neurosurgery was mentioned also because for many years we had a neurosurgeon, Dr. Ford, that worked at the pain clinic, and he will take care of some interventional procedures in this population. They require training, the resources that we were about to have, and triaging mechanism for the referrals in terms of timing and in terms of the moment to be seen. And require a consulting service, and we needed to have some facilities given to from the hospital to do procedures or to do some exams in these patients. So how the model of interventional pain would fit in the cancer pain clinic. The first thing was to have a dedicated OR time for this patient. So we said, okay, we're going to collaborate, and if we think that this is an emergency, we need to go in the OR and book cases that need to be done today and not in 48 hours more, today as a category 2 in the OR and get OR time and get it done today. The administration accepted that. So what kind of things would we put forward? Sometimes epidurals, and with that we settle the situation, and then we think how we're gonna get the patient out of the epidural and get the things going. But at least I will give a break to the patient. Intrathecal ports, kyphoplasty, vertebroplasty, cementoplasty, neurolisis, continuous peripheral nerve blocks, and stuff. So we needed to have the resource of OR available cases. Then this is what I was talking a little bit about. In the clinic, what we needed was to start small and grow slowly, was to have a part-time clerk. So this person would be in charge of working with us the 2 days a week that the clinic was running, Tuesdays and Thursdays. So that person would be there 2 mornings, and she would organize the charts, but also would administer to all the patients the questionnaires that they had to fill out. So we collected a huge amount of information with many questionnaires that patients were filling on the camp, first time and follow-ups. We needed a full-time nurse, hopefully, but at the beginning we got a half-time nurse that would work Monday to Friday. So Monday, Wednesday, and Thursday, she would work in the morning in her office to do the triaging, do the booking of the patients, call the patients back, and organize the smooth function of the clinic. And the Tuesdays and Thursdays, she would be in the clinic with us, seeing the patients. And we needed space, physical space to do this. And we had 2 pain specialists. One would work on Wednesday and Tuesdays, the other on Thursday. We had 2 or 3 palliative care physicians, 1 radiation oncologist, and on call we have the largest orthopedic cancer program in the province of Quebec. So this person will be on call if we needed any support from the site. It was very nice from the get-go because the people had a fantastic interest in getting this going and going well and working together. So we will sit all with the patient at the beginning. The first visit, the patient will see everybody all at the same time in the room. Typically, in the first visit, who would sit in the chair to write the things would be the palliative care physician. But if the patient, after the first meeting, was deemed to go more on the side of the radiation oncologist, in here, the first follow-up is the radiation oncologist who's going to drive the team. Okay? The dynamic was very simple. We had 3 boxes where we put the patients, and we'll go one by one. But once we saw a patient, we'd go sit in a small conference room, discuss the case, have a plan, and the person who was about to be in charge of the plan, the oncologist or the interventional physician or the palliative care physician, will go back with the nurse, implement the things, and get all going. Then see the next page. Referrals were accepted if the patient had the cancer diagnosis, and we mentioned that. Okay. The role of the nurse clinician, Sarah was our first nurse in there, was to do the triage of all the referrals, manage the clinical work on Tuesdays and Thursdays, the care coordination behind curtains on Monday, Wednesdays, and Fridays, and telephonic intervention. When the patient was calling because something was going too well or too bad, she would take care of that part. So at that point, we were starting to work in this endeavor, and the things start to go well very fast. The number of patients referred to us was going like this because we would start getting referrals not only from within the McGill community, but the word started to go out that this was working and working relatively well. So we start getting more and more patients from outside. We opened officially in March 2011, and this was the thing like 2 or 3 years down the road. The radiation oncologist, one of the palliative care specialists, the clerk, a nurse, another palliative care specialist, anesthetist, and palliative care. So this is about probably three or 4 years after we started. And this is the typical scenario where we have the patient and the group talking to him or to her in the initial contact. So soon we realized that the expectations regarding pain relief in the population were fairly simple, but sometimes the speed that the patient expected this condition were not there. So they wanted great efficacy in the pain control. They wanted to have the pain control to improve a little bit their quality of life. And also we figure out, I think the pain physicians knew, the palliative care were not that clear on that, but the patients wanted to have the less possible pills. And because of an issue of having to take them, but also some patients were a bit confused, so it was not that clear that we were taking the pills correctly. So the least possible pills they feel more comfortable, more confident they could manage. Not everyone had somebody to be with him or her to make sure that the pills taken were the correct ones. They wanted also to have a low profile of side effects of the stuff they were given. So many people were people that had cancer, but they were still working. And they didn't want to be asleep at work. They wanted to have a sharp mind, to concentrate. They wanted to drive and do things. And when this became more apparent, it was very nice because it opened a door for interventions that could greatly relieve the pain and reduce the amount of pills they needed in order to achieve their goals in terms of pain relief. This issue of the possibility of a freedom in the sense of not having to depend of the cancer pain clinic is important for us here in Canada because of the distances. We have a huge referral of patients from Nunavut that sometimes are 2,000 or 3,000 kilometers away from Montreal. So the least needed contact possible was very appreciated by the families and the patients. You see how far can be Montreal from Baffin Island and so on. So the pain mechanism of cancer, I don't want to go through them. You guys know this very well, but sometimes in cancer pain it's good to keep an eye in order to understand why some of the interventional pain procedures that we can offer to complement the palliative care work can be so useful. These are some of the pain assessment instruments we use in the clinic. This is the Karnofsky, the cage for patients that use alcohol, and the Edmonton Symptom Assessment System, the ESAS. the brief pain inventory. So out of those, everything has been kept till now except the brief pain inventory, and there's an enormous amount of data that has been collected over the years. So if we see the WHO ladder that has been implemented worldwide very successfully in many areas, there is a lot of advantages, but there is some questions that still remain and some weakness that could be improved by this work together with people that do intervention. There are new drugs available. There's some other forms of administering the fentanyl, but there is a lot of concern regarding fentanyl. Drugs like buprenorphine has been made available. Carbamazepine in neuropathic pain, and opioids and non-opioids combinations. And also, we have some warnings in certain areas that you have to be careful with. Is interventional the fourth echelon in cancer pain? Probably not. Probably interventional is something we can put at any level, and we can facilitate the work of the patients in dealing with their pain in a much smoother way if we offer certain little things here and there from the beginning. And there's many reasons that support that. So very often we were consulted before by palliative care saying this patient is getting toxic and we cannot manage the pain. What you can do. So that is still one of the main reasons why we offer a patient a good interventional technique. What to do with the patient that still at max dose is not toxic, but patient is still there. Sometimes there is a perceived evidence advantage of some procedure. Say patients, for instance, with pancreatic cancer, where you can go do an injection, or a patient with a retroperitoneal cancer, do an injection and really reduce the pain markedly, to a point where you may get rid of the opiates and stay with viral analgesics. And how may interventional pain specialists help with that? We can do neurolysis. For instance, this example of a patient that we denervate the esophagus because of esophageal cancer that was very hard to manage. Was a young patient. She was getting toxic and still had pain. And we presented this experience with over 5,000 patient day intrathecal catheters that basically showed the following. The VAS improvement immediately after installation of catheter was 6 points. So if the patient had a VAS of 8 before the installation, it went down to 2 in average. At 2 to 8 weeks, 8, 6 to 8 weeks, 9. So that is mixed with sometimes some of the medications that the patient was receiving. But you will see that 46% of our cases had a quality of life improvement of 100%. And another 48% at least had at least 50% at 2 to 4 weeks. All of these patients, including this study, were referred to us by the palliative care team. So there was a tremendous collaboration in there. At 2 to 4 weeks, 82% of the patients were totally free of opioid side effects. Many of them still with opioids, but free of the opioid side effects. All catheters were placed successfully. No catheter-related complications were recorded. And finally, do there were any issues? Yes. Lower weakness and numbness, transient for 9 patients after 2 or 3 days of titrating the medication and adjusting the type of medication, it went completely away. decreasing level of consciousness very often happen. But if you're careful when you do the initiation of the treatment, it's much less. What's happened, patients have a huge amount of opioids. You cut the pain with an intervention, and the patients get mentally clouded. Decreasing respiratory rate in one, urinary retention, nausea. And there's another area where we did great work for patients with bony disease. And for instance, in this case, this is a woman, 36 years old, with a terminal breast cancer. So the palliative care team from the Royal Victoria presented the case to the orthopedic team, and there was a fracture in there. And the orthopedic says, we have nothing to do with her. She probably will not tolerate the surgery. Just give more morphine. When they consulted us, the patient was obtunded. The family wanted to interact with her, and the patient also so young. So we did just rectal plexus block, and then we put a needle all the way down to here, fill it up with cement, leave the needle in there, tighten at the top. The patient was pain-free at the end of the procedure and pain-free for the next 2 weeks until she died. It's such a simple thing. I mean, 20 minutes to do the thing. You change the life of the person. So this kind of things can be offered when you have an integrated program where the people understand what you are doing on the other side, what you are offering with the little things that you can give to the patient. Other bone-related procedures, the patient with a MET immediately above the acetabulum, put the needle in there, fill it up with cement, and the opioid requirement went down by 85%. Vertebroplastics, and this is disability improvement after vertebroplasty reported by the patient. So 60% of the patient reported significant improvement in their disability after cleaning the vertebrae with some cement. Okay, so what's happening if the patient, like the last patient that I showed you with the humerus full of fluid and a fracture, could not have cement. Yeah. We can implement continuous peripheral nerves, we can do erectospinal blocks, we can do tap blocks, we can do so many things for these patients. But the important thing is that the team understand that these tools are available, are there. They're not complicated to do. Years ago, when palliative care was starting, interventional pain was very far away. They were very that's the word about it. And why? Because there were very few people in the world that were very skilled on doing the thing. Now we have fantastic training programs in pain management with interventional techniques, and we have much more specialists that are very skilled and very precise in doing this kind of intervention. It's a young guy, again, with a tumor in the left arm, with a continuous block in there. The patient is going to go home with a bunch of bottles like this. He will change at home every 3 days and would come for follow-up every 2 weeks. Simple things to do. So this is in the Torres del Paine National Park. Combination that we saw at the beginning was in the first, I think, these are new patients. In the first year, we saw about 650 patients and follow-ups in the first year, with mostly lung cancer, breast, and these are mostly prostate. We saw a bunch of hematology patients that were multiple myeloma. The hematologists were very fond of sending us the patients for vertebroplasty. They like it a lot. This is per year. I think these are the different clinics in palliative care. This is the cancer pain clinic, rehabilitation, anorexia, cachexia. So this is numbers of patients that were and the change from one year to the next, an increment between the first and second year, and we stabilize between the second and third. This is important. The waiting time in days for the fiscal year 13-14. The average was 16 days for the cancer pain clinic. So we were able to, having only 2 days per week, we were able to manage patients to be seen within 2 weeks. And if the patient was really an emergency, we would be seen very fast in the next available appointment, probably the week after. Okay, so if we see the ESAs change from the first to the third visit, you see there was a decrease in the pain indicator, there was an improvement in fatigue, there was an improvement in nausea, there was an improvement in anxiety, and the patients in general were doing better. And basically the ESAs show the same thing between, here we have year 1, year 2, and year 3, and we see that if you go comparing, there is an improvement in every component per year. Total visits for the cancer pain clinic, you will see year 1, 2, and 3, and the total numbers are 60. 618. This is half a year. 6 months. Right. And that continued growing. And now I understand the clinic is running around 1,000 patients per year. The average pain intensity between first and third visit in the year 1, first visit, third visit, year 1, year 2, and 3. Now, this is another aspect of pain control. Is there any evidence that a good pain relief in cancer therapy improves outcome? There's a lot of controversy regarding this. There's a lot of papers that have come out. I don't think it's conclusive, but one thing I can tell you is the following. In that population that I presented before, where we have 5,000 patients a follow-up, patients with intrathecal catheter, they were able to reduce so much their use of opioids and many other medications that were treating the side effects of the other medication and the other medication and so on. The impression of the palliative care team is that the patients were living a little bit longer than if they were funded with medications in order to get the pain under control. There is at least one study done with intrathecal pumps that showed an improvement compared with optimal multimodal analgesia. Very nice study by Peter Statz, a number of years ago. The important thing I believe is that we see the people together in the clinic, and you perceive the improvement over time. You perceive that that patient that came in this situation, in spite of the fact that they are deteriorating because of their cancer progression, they're having a better quality of life. They're so thankful for the work you do for them because the pain is better controlled. Okay. Is an integrated approach to cancer relief feasible? I think it's totally feasible. And you can do it here, anywhere in Canada, because of the type of healthcare system we have. In other places, it would be super expensive to implement. It would be super complicated to make this integration of specialists. I'm convinced that here in Canada, anywhere in any province, this can be done. And you have such a good group of pain specialists here, and I'm sure the palliative care team is so interested in integrating and working together that this can be, I'm sure, well developed in this institution. Thank you very much.
All right, so thank you for your talk, Dr. Sancho. We do have, how do I find out about the people online?
Where's the nice man? Anybody online?
Yes, you do call that.
I'm going to get a question online. Okay.
There's a couple of questions
If
here.
there is one, let me know. Let us know.
Okay. Well, I guess,
Yeah. Right.
We
We all are questions. So we are the
Yeah.
palliative care team at the outpatient cancer center here. So we're very
This is the
appreciative.
entire
Right. And I'm also originally from Montreal and trained at McGill, but before you were there. So first of all, thank you very much for the presentation. That was wonderful, and I learned a lot. And I think another thing that you could emphasize, it might have been in one slide, but to me, what I've really seen doing this palliative care in cancer for 20, 25 years now, is that because of changes in chemotherapy and immunotherapy, patients are living much longer, and it affects us in palliative care, and it certainly affects their pain and symptom management. And so there's more and more of a need for all of us to be involved with these patients. 25 years ago, they just died. So some of my questions really are more around the practical details of what you talked about. So one is a point of clarification, because you had said the nurse was a half-time nurse, but then you said Monday, 3 days a week she was doing the triaging and 2 days she was in clinic. So were those each just half days or?
Half days, yes.
Okay,
In the afternoon, she
Yeah.
will work in some other business.
gotcha, okay,
But
that's,
every morning
Yeah.
of the week, she will do cancer pain.
okay,
As you mentioned, Monday, Wednesdays, and Fridays in her office, and the 2 days in the clinic.
So,
and then,
sorry. I say, so in those afternoons, who would field patient-related issues in the afternoons? Or did they typically,
what?
or did non-urgent ones wait until the next morning?
like,
The patients knew from the get-go that they were, the clinic was able to be contacted any day of the week in the morning.
Okay,
If they had an emergency thing, then it was ER,
okay.
and the ER would
So
contact
it's-
them.
And then for the clinic structure, like how long would you put for a new patient appointment, and how frequently were the follow-up?
That's a great question, because it's an area that is hard to define. So the first follow-up was about to be booked depending on how unstable the patient was. So if we thought that the patient required a follow-up a week after, he would come a week after. But the nurse would call the patients every second day until she felt confident that the patient can come next week and so on. If the patient was stable, let's say it was a patient with, for instance, multiple myeloma, that was sent for a particular procedure, which was perhaps a vertebroplasty in typically T12 or L1. The procedure was done, patient was stable, patient could come in 2 months after for a follow-up, then in 6 months, and then discharge. That's it. And the timing of the follow-up was upon the acuity of the situation.
So,
Oh, sorry.
so one of the thoughts I have in listening to you is that the population I see, there are really two different kinds of groups of patients. There is, and I think you started to try and bring this up, we're getting a cancer pain population who is getting good disease control for many years and really needs a more chronic pain management approach, needs to see the psychologists and the physiatrists and all of those folks. So I'm guessing, or I'm wondering how you sort of dealt with that group of people, because that's different than the acuity with some of these other, of our palliative care patients who we've really done all the medication adjustment you can do, or we've looked at them and gone, this is going to be a tough pain to manage. We need to get something going, like some other strategies going.
You're right on. You're right on. So I would expand that idea in the sense that there's more like 3 groups. One is a chronic pain population, cancer pain population that needs immediate attention because of pain. And then we have the cancer survivors. Those guys are people that in most of the cases have chronic neuropathic pain, that particular population. And they don't have cancer anymore. So that population that doesn't have cancer anymore doesn't fit in a chronic cancer pain clinic. They need to go to a chronic pain clinic. And that is perfectly okay. It's perfectly okay. And the patients actually appreciate that because they said, I'm beyond the cancer. I have these complications now, so there are other guys that don't deal with cancer, but they're gonna deal with my pain. And it's a sort of reinforcement, or it's a positive reinforcement for that patient.
The difficulty from my point of view is the wait time to get them into a chronic pain clinic. And so I keep getting the oncologists like sending them to me, can you do something? Because, you know, they have all this pain and they keep presenting in clinic.
There is an alternative to that, which is the following. And I was talking to Norm about collateral about this earlier today, which is when you have your patient stabilized, let's say you try to send them to a chronic pain clinic and the waiting time is 2 years, stabilize the patient, and then send it to his GP and tell the GP, look, perfectly okay managing these things, and you have had some training in pain or not, but if you have something, just give me a call. You don't need to send the patient again. Give me a call and I'll help you over the phone. And that can easily, you know, manage those overflow to the chronic pain clinic.
But I know I'm monopolizing a little, but in the last year, 2 years, the transfer of patients back to the family doctors has gotten quite difficult because of a fear and a reluctance of using opioids, if that's part of the program to manage. And so you get family doctors who you try and transition them back, and they get sent back to you a month later because the family doctor refuses.
Yeah, I don't know if this pass also in particular with the patient of having methadone. In Quebec, at least for many years, the Collège de Médecins de Quebec requested you to take a course to be able to prescribe methadone.
Yeah, it was the
If
same.
you and
here.
me, and with all due respect, it's crap. I'll tell you why. I'll tell you why. Because if you have enough experience with methadone, you will recognize that it's very easy to manage. You need to know only 4 or 5 things, and that's it. From where I come, when I trained as an intern, I'll tell you what, the post-op analgesia for a C-section was methadone 10 milligrams intramuscular every 8 hours for 2 days. I never ever saw a problem with that, ever. So it's a very safe drug if you know that there are some issues with the ECG and there is some issues with accumulation, and you need to try titrate. But if you some way do an expansion of your area of coverage, inviting GPs to have meetings with you guys,
Yeah.
I think it's good.
Yeah, it's a big problem.
It's just a function of the rollout of all of the opioid crisis lately that family doctors have become much more timid about.
But that's for non-cancer thing, which is very odd.
But if you look at studies of
They
cancer,
forget the non-cancer thing.
The hard part is what to do with the cancer survivorship pain, who are sort of non-cancer pain now, but whose pain may be very different in its etiology than many of the other chronic non-cancer pains were, and how to apply those guidelines to that particular population doesn't fit. But I don't want to change the topic at all, but I'm not sure we're going to necessarily come up with a great solution for that problem.
I think
and I have a few more questions about the
Please
logistics
go ahead.
of your pain program, because I think it is something that that we experience every week as being a huge need. Seeing patients who have these complex pain syndromes, opioids are just not cutting it. The side effect profile is really not favorable, and especially when you're not dealing with somebody who's imminently dying, who might actually have like a year, or maybe 2 years, 3 years now with immunotherapy, and how to manage that. From just a practical understanding point, I was very interested in the volume of patients that you guys were able to put through with very, very good wait times, with only 2 half-day clinics a week. How many patients were you successful successfully able to see and sort of assess within those half day?
On average, we were looking at, we were following 8 patients per day,
And with those, and what would be the blend of new and follow-up?
news and follow-ups, yes.
So 8 total news and follow-up.
Right, so follow-up is very quick.
Yeah.
Usually it's 15 minutes visit,
Okay.
and we'll come up with a new strategy, or we'll say, you know what, you're doing great, just keep going, or we'll say, you know what, we need to take a bit more time, or we need to do this lab test and so on. Usually it's a very short list. So the new patients typically will take more time, and as I said, we have 3 offices to see patients.
And were there patients, so I'm just trying to think of our patient population, often there's pain, and that may seem to be their primary referral reason, and then you meet the patient, right, and it's like pain and constipation and nausea and this and that, and there's no support at home, and the problem is much bigger. In the pain-related clinic, were there patients who would, for example, come to the pain clinic specifically only to manage the pain component, but then also be followed in the regular palliative care clinic for more sort of holistic palliative
That's a
approach?
key
Or how
point.
did you blend all those?
It's a key point because
things?
if you keep accepting, and taking care of pretty much an holistic approach to the whole patient, cannot go.
Which is what typically
So
the palliative
what we
care
would do
clinic does
was to stabilize the patient exclusively from pain permission.
in that clinic.
The palliative care physician in the clinic will give some immediate correction to other problems
Okay.
and will refer the patient back to the palliative care physician that sent the patient in the first place, saying, look, you have some problems here, and we are not going to fix. So
So you
I'm gonna
did
help you
some
with the pain.
focus in there.
You fix this. I have done this, this, and this. You have the patient now, but you have to take responsibility for the rest.
And did you have patients who were dually followed? So for example, who would come and see the interventionists for their pain management or follow with the pain clinic specifically for their pain because it was unusually complex, as well as have ongoing follow-up with the palliative care team for their more holistic approach, or did it end up being sort of one or the other depending on?
I don't completely get the.
So I can imagine a number of our patients that we've seen. So for example, a patient who does have a limited prognosis and would benefit from sort of a holistic palliative approach, but who one of their problems symptom-wise would, for example, be significant neuropathy from a plexopathy from tumor invasion. So could that patient's pain needs be managed with follow-up, for example, either intrathecal catheter or some type of spinal block and be followed in the pain clinic, but then also be followed with their palliative care physician for all of the other needs?
Absolutely, I understand. Yes.
Okay.
Yes.
Okay.
Very often, what would be the scenario is that their palliative care physician, primary care palliative care physician will say, this patient needs to be seen by psychological services and by the cancer pain clinic. So we refer the patient to those 2 clinics that are under the umbrella of the cancer support
Okay.
at McGill University Medical Center. So they will be seen in consult, they will be treated and co-managed with the primary specialist.
And when you, so this will be the last one, then other people can. This is just, I'm really interested in this model. I think it would be really useful to actually see and stabilize some of the acute referrals where their acute issue is pain, but they also need all the other palliative things. So if they were to receive sort of an acute issue and it looked like pain was going to be the thing that was basically going to bounce them into the emerge, would you ever dually triage and say, okay, we're booking a consult in pain, we're also going to book a consult in palliative care?
That's a scenario where the patient is referred by somebody who is not a palliative care specialist.
Right, like, so yeah, so I'm thinking of our patients where I look and say, yeah,
So
you
the
know, what, they
patient is
probably need.
entering the cancer support through the cancer pain clinic.
Okay,
So
yeah.
we're the first to see this patient. So we see what the issues are. We concentrate on pain, and we concentrate social services, psychological support, cachexia, anorexia, cachexia clinic.
And was your nurse the one who was triaging all the referrals coming in? Who was doing it? Was your nurse, was the nurse the person who was triaging and sort of flagging the referrals coming in?
Yes,
Okay.
yes, she's the one. And
So I got 2 questions.
Number one, who, as far as this program is concerned, how is it being funded? Because I imagine like you got a lot of procedures there, vertebroplasty, kyphoplasty, tracheal pump.
Yeah. Like that's all paid by the provincial government.
Provision cost. So
It's
you have
like that. It's like caring for everyone.
a separate program to fund for the cancer.
Funding for the cancer pain was required basically to pay half-time nurse and the clerk. So the Alan Taylor's foundation, Louis and another foundation, put the money at the beginning. With time, the hospital put some more money, and we managed to transfer the cost mostly to the hospital. It's normal in Quebec that everybody gets the care for everything, and the care is paid by the government. And this is not different. If you come from a colon, it's the government that's going to pay for your care. If you are cancer, you have the same right to get good care than someone who has an acute colon, cholestatic, right?
So the hospital is willing to pay intrathecal pumps if it's needed. If the doctor says, yeah, this is definitely needed.
Yes.
And also, what about physicians? Are they salaried or are they fee for service?
Fee for service. That's in Quebec, that's the way. Fee for service.
Is there any other online questions?
No.
I have a practical question. I was very impressed to see that it sounds like you have daytime to do your procedures and pump implants and things like that. So that's part of the operating schedule.
Right.
And that's, now how is that negotiated into a progressively restricted healthcare system?